Welcome back to another edition of the Hart2Heart Podcast, and my guest today is Dr. Michael Mindrum. He's an obesity specialist working out of Nova Scotia. So Dr. Mindrum, welcome to the show.
Thanks so much for having me, Mike. Glad to be here.
So there's a lot of things that I want to talk to you about today. You seem to know, incredible amount of knowledge about obesity and how to treat obesity, and that's really what I want to get into today. But just before we kind of get into the science and the nitty gritty, could you just give the audience a little bit of a brief background about yourself?
Yeah, sure. I'm, like you said, I'm a obesity specialist. Have a background in internal medicine. Practice in Nova Scotia. The closest town is Kentville, where I live. It's about an hour outside Halifax, up in eastern Canada. And originally from the States, so grew up in Louisville, Kentucky, did training there, in Hawaii, then Vermont. Got caught up with a Newfoundlander, got married, and now he's kind of settled down here in the valley. And family, work. It's a full, rich life. So it's been a lot of fun.
Well, can't go wrong with marrying a Newfoundlander.
Absolutely.
Obviously, I'm a little bit biased saying that, but being a Newfoundlander myself, but happy that you found her, and I guess she dragged you to Nova Scotia. So
she did.
That's awesome to hear.
I'm happy she did.
Yeah. So you enjoy it out there, it sounds like.
Yeah, it's great lifestyle. Have one stoplight between me and the hospital. So life is good. And we have almost everything here. We're about an hour outside the city if you want to get there, but rarely do we need to or feel the need to go in.
That's awesome. Well, it sounds like you got a real nice life there. So that's fantastic. And I'm sure the Newfie wife just makes it even all better.
Entertaining, fun.
That's great.
Yeah.
So, we're going to talk about, mostly obesity today, I think, because we know that, that's certainly something that's really affected people for, the last few decades, obviously more so in the past. So, maybe we'll just start there. Like,
Sure.
In your opinion, Dr. Mindrum, like, why are there so many people struggling with obesity today, say, versus, 50 years ago or 100 years ago? Like, why are the obesity rates skyrocketing?
Well, you look back and it's a bit of an exponential curve, I think. It probably started before 1970. The rate just wasn't going up very fast. But then there was definitely an inflection point right about that time. And it happened, throughout North America, both sexes, different ages, all ages, from youth up to older age, and ethnicity, socioeconomic backgrounds. You just see a mass change all around the same time. And it's been accelerating more and more over the last couple of decades. So, we kind of think back and think it's this interaction between our genetics and the environment. And, some people are like, rightly say, well, it can't be the genes. Our genes clearly haven't changed in the last 50 years. And we can talk more about that, but there's this genetic environment change that's happened, and primarily the environment's changed. So there's something about the environment humans have found themselves in the last 50 years that has led to this rise in obesity, especially in severe obesity. So that's gone up 4 to 5-fold, where more mild obesity has grown, but not at the same pace.
Right. Because I think that when I last checked the stats in the United States anyway, it was something like 70% are in the overweight range. And again, we're using the BMI, which I know is not the best, indicator, but and I know there's even been some recent research saying that we may try to get rid of it altogether in some ways. But for the most part, still, it's not too bad, just because for the most part, most people who fall into the overweight or obese category, especially, don't have too much muscle. Yes, there's some people there, and maybe it's 5-10%, and that's probably even being generous. But
BMI is a good metric on an epidemiologic level, and it falls apart a bit when we're seeing patients one-on-one.
And then I think the obesity rate in this, the obesity rate is up to like 42.5% or something like that. And you mentioned about like genetics and environment, and And I learned this from Lane Norton. I'm not sure if you're familiar with him, but he had tweeted out maybe a couple years ago something like, I think 50% of people with obesity have a diagnosis of PTSD or some kind of diagnosis of like mental health. So do you feel like that that has contributed to it as well? Like people are just, maybe more stressed, or maybe they've experienced, in some ways like more trauma, and then because of that, that's kind of contributed to it to some degree.
I think you'll find increased rates of adverse childhood events in people that live with obesity. But it wouldn't be a good assumption just to think when we see somebody that that's happened. But I think it can affect it, because adverse events can lead to some kind of emotional dysregulation. And when we're suffering, we're looking out for ways to cope with that. And sometimes, depending on one's appetite system and genetics, people might find that, say, the ultra-processed foods provide some kind of, it might be non-conscious, but relief from that suffering, or find just that as a good coping mechanism to deal with the angst. And I think because of that, it can kind of propel weight gain through childhood, adolescence, and adulthood. And the other part is obesity in itself just leads to a lot of distress living in our society. There's a lot of bias and stigma and judgment about living with obesity. And that kind of gets wrapped up in a person's sense of self. And the previous adverse childhood events or traumas or whatnot all gets wrapped up in it together. So it's, the person as a holistic being, all that's incorporated into them. And weight, it's a sticky thing in terms of one's emotional reflection of their self-esteem, and all of that.
And in terms of like, environment, obviously like the environment that we live in today in 2025, almost at 2024, is, vastly different from in the past. And, I'm really talking about the availability of fast food, and, other foods that weren't really available in the past. And, I know that you've talked about before, like it's not necessarily all about, willpower. And like, there's even been some like very like candid UFC fighters who obviously have an insane amount of willpower. They're able to do these, grueling workouts, able to, fight in front of thousands of people under like incredibly high pressure. And even some of them say that like, when they drive by the fast food, they just can't help themselves, and they just have to stop and eat. Johnny Hendricks is one guy who's kind of been pretty open about it in the past.
Mm-hmm.
Just couldn't make certain weight cuts and stuff like that. And so do you feel like the environment like is and the availability of the food has really contributed to it?
Yeah, I kind of think about it like we were evolutionarily in one place, and our bodies and the environment kind of evolved together. And sometimes there's nostalgia of what that was like back in the hunter-gatherer days. It was a tough time for humans. But that appetite system and how it interacts with the environment for survival is still with us today. And all of a sudden, like in a flash, we found ourselves in this crazy environment with artificial lights and stress and food everywhere. The composition of the food is different. There's now chemicals that we don't know exactly what they're doing, that we can consider endocrine disruptors or obesogens. All of this is just a really artificial experience for our inherited appetite system. And I think it gets hijacked and leads to overnutrition. And it's really spread across the population. That propensity for that appetite system to get hijacked is different person to person. That experience of the UFC fighter driving by fast food and having a hard time shows you like this gentleman clearly has high discipline, restraint, courage, grit. You'd trust him to go to war with you. And then he has a hard time not going to the drive-through, but he's okay stepping into the ring facing possible death. Like
Right.
this is a tough dude. And it's like, we sometimes think of this power of appetite and wanting for food as kind of like a hobby and something that you can just choose. It's not that big of a deal. And for some of us, it might be the case. The power of wanting isn't there, and we don't think it's that hard. But a lot of that power of, say, driving by the fast food and wanting to go is non-conscious, and it's kind of adjacent to the desire to breathe if we're underwater too long. And some restraint, for small wantings is not too hard. We can refrain from that. We can call that discipline or willpower. And other time is really powerful. And unless you're walking in someone's shoes, you don't really know what they're experiencing in terms of that wanting and appetite system. And so that's one aspect of it in terms of kind of separating kind of this behavior change, understanding kind of the underlying neurobiology there. That's a really cool story that your UFC friend shared with you.
Yeah, I mean, there's definitely, a lot of those people out there who, again, have discipline in certain areas of their life, but they just, don't have that discipline, in one area, So I understand, what you're referring to by, when certain individuals just, they are able to be disciplined in one area, but, in other areas, not so much. And then in terms of like the food that's, available today, like it seems like in the past, there wasn't too many foods that were high fat and high sugar at the same time. Whereas now we have lots of foods that are high fat and high sugar. So, back in the day, if you ate, a ton of berries and that kind of thing, which, would have, some sugar, and albeit, berries have fiber and stuff like that certainly make it healthier. But still, it was more or less like, fat and sugar were more or less separated. But
Absolutely.
now we have, lots of food with both of them together. And you feel like that combination has also led to some of the rise in obesity?
Absolutely. There's been a lot of good research into that, and more research needs to get done. But definitely when you pair up high carbohydrate, especially refined carbohydrates, with fat, it's going to hit the called a hedonic center of the brain. And this is the limbic system just kind of surrounding the thalamus. And that for some people, like if you do scans, those that are prone to obesity will have a higher acceleration of the activity in that area. And that you can say that's liking. It's kind of like joy or liking, but it's also a learning center. So the deep brain is kind of learning. If it gets that a rise in dopamine, the brain learns. And so the next time you encounter hunger or emotional stress, the deep brain has learned that it should go to this high carb, high fat food, which is a larger reward to cope with that wanting. So all of a sudden it switches from just liking a Snickers to wanting it. And the high carb, high fat, and that some of it kind of switches into almost addiction for some. But wanting and habit is another, there's kind of a spectrum there. And it happens for all of us around food. But the high carb, high fat can be really problematic. And you're right, it's not seen in nature. Our hormones and the brain biology isn't used to dealing with high carb, high fat at the same time. Usually there's protein and fat, or carbs and protein, but not the combination of those. And the food products that are developed, it's a competitive market for our attention, and they've kind of gone through their own evolution, and the food scientists just through economic pressures to compete with each other to find products that we really, really want. And that's going to lead to overnutrition.
And you mentioned too about dopamine, which is interesting too. I'm just kind of thinking, I've heard, Lane, I think, talk about this before. I think it was Lane, who mentioned that some people, when they eat certain foods, they get a higher dopamine spike than others. So obviously they would get, more addicted to it. Is that something that is true or that you found in your research and maybe
Yeah,
contributing to obesity? Yeah.
for
Okay.
sure. I think dopamine's often, I previously thought it meant just simply liking, like and you kind of think of hedonic or hedonism as just liking and wanting, or just liking, but that it's also more, I think, better understood as a learning molecule. So our just like artificial intelligence, you reward something and it learns. Our deep brain is like a supercomputer, just like that. If it hits a reward, the brain's gonna learn and remember and recall. So if you have a higher reward system for that food, we're gonna learn and remember it better. And that happens really on a non-conscious level. So it's under the hood.
So I guess then my next question is, if someone is struggling with obesity and, certainly we will get into the GLP-1s like Ozempic and that, but in terms of just behavioral change, like how do you get someone's behavior to change? Like, do you have them, chat with a psychotherapist, or like, what is sort of the first step if someone says, okay, now I've made it, conscious in my brain that, I know that when I pass by fast food, it's
Mhm.
going to be very difficult for me to stop. Or, if there's at a party and there's, some chips out on, on the, on the tray somewhere, I just can't help myself. So like, how do we, change that behavior overall?
Awesome question. It's a interest of mine over the years, because I think if you are in medicine and you're thinking about preventative health, you realize this is all about behavior, and behavior can include taking a medication, and humans are really bad at taking medications over and over. But it could be exercise or nutrition or not going to the fast food or flossing one's teeth or any of these things. And behavior change, if we're struggling with it, it's because it's hard. Our habitual tendencies are really powerful. And, just as a framework, most of our behaviors are automated. Most of our thinking is automated. And that's, there's a book, Thinking Fast and Slow, that kind of goes through this, that system
Daniel
one.
Kahneman, was it?
Yeah.
Yeah. Yeah.
Behavioral economist, Nobel Prize winner. And the system one's extremely smart and brilliant. It works for us most of the time, but sometimes there's something that's off, and it might be something we want to change, like going to McDonald's after work. But that system is mostly working well for us, and then there's something we want to change, and then it's like, okay, how do we do that, and why are we struggling? And so I could talk about this a long time, and I don't want to go on a monologue, but what I would say is, first, reflecting back, what's motivating the person, and finding out who they are and what their goals are. Like, what is it that they're wanting to do, and how do they want to see themselves in the future? What do they find of greatest value? And so sometimes it's just asking, so why refrain from going to McDonald's? Well, I want to lose weight. Why do you want to lose weight? It sounds like a silly question. But it's like, well, I want to be thinner. How come? What would you do with that thinness? Or what would you do with that mobility? And eventually it's like, hey, I want to ride my horse. I haven't ridden a horse in like 20 years. And that's something they really love to do. And now they can kind of come back and find something really meaningful that kind of pulls at their deeper heart to say, okay, I can do something hard here because I can recall why I'm doing it. And so once they have a purpose in mind, then it's something you can start working with. And the other is really starting with understanding readiness. And your UFC friend, for instance, might be ready to do some crazy workout, but you ask him, do you find going to McDonald's a problem? And if he says, not really, does it bother you? A little bit. Do you want to change? Yes. And do you want to change now? Yes. Well, that you can find them in an ambivalent state. And if they may know they don't want to go to McDonald's, but if they're ambivalent, they're kind of deeply pulled in two different directions. And unless you kind of focus on that ambivalence and understanding the value of going to McDonald's, What purpose is it doing? What is it going on inside that makes them feel comfort or relief, or that it's difficult to change? And that's really frustrating to deal with restraint, and all those things. So you kind of focus on initially the resistance to change and the value of it, because that's usually skipped over. And as doctors, we often just get to the solution and the change and give advice, and they leave and they come back and they haven't done it, and they feel, kind of guilty because we haven't gone through the mechanics of understanding their readiness, or maybe they're totally not ready to change. And if we start talking about change and they're not ready, we're just pushing them away. We're on a totally different page and we're wasting time. Instead, like if there's no readiness to change, it's understanding the beliefs or the values of why somebody's not wanting to change that. So it's really a fun experience that allows the clinician not to hit their head off the wall, and for the patient to feel seen and feel like they can tell their truth, where they feel like it's okay to talk about liking to go to McDonald's, or what's the upside of smoking. They like going outside and they have a new girlfriend or boyfriend and they sit out there and smoke like that. That sounds, there's a lot of value in doing that. No wonder it's hard to stop if, there's meaning in that way. And then it's kind of like coming back to that compass of change, doing something hard. They're in that person's in conflict. They're like, I want to ride my horse, but I keep going to McDonald's. Like, how do you reconcile these two things and understand? And sometimes there's guilt and like, I can't believe I keep doing this. It's not what I want to do. Well, if you know your purpose and you know the purpose of McDonald's, and you start finding healthier habits to replace that function. So there's a lot of mechanics we can learn from, say, behavior change psychology that we don't get in medical school, and we have to go out and seek that. And so like in Obesity Medicine, we're starting to incorporate as one of the pillars, but it's something most clinicians have no idea what it is. And so it's one of these pillars that you really need kind of a framework of working with and a community of practice. And we're not, every day is every experience is a new learning experience. So it's kind of like getting competency in that area is more of like an aspiration.
So it seems like in a lot of ways, what you're saying is that we're focusing too much on the treatment and not enough on the why. And we need to get to the why first before we get to the treatment.
Yeah.
And, one thing that comes up, and it's certainly not everybody, and I'm not trying to, shame or guilt anyone, but I have heard, some people say, well, I got in shape or I lost weight because I have kids and I want to be, an example for my kids. And that's sort of, the why, like I don't want to be, the obese father who then, has an obese, child and so I need to get in shape and be an example for my kids. Is that sort of one of the, maybe bigger levers or reasons why, you found, or is it just sort of all over the place? Like there's so many different reasons why people, do have some type of positive behavior change.
I think everybody's different. And that's the kind of the fun part, is finding out when you meet somebody, what's making them tick, what's making them drive. And sometimes it is wanting to be more active with their kids and being able to go out on the beach with their kids, or go swimming and feel comfortable in their skin. Sometimes it's getting on an airplane and going on a trip to Europe or Disney World.
Sorry, I just want to interrupt there because that's a really good point, just because I had a fella, Dave Dana, on my podcast, and he's got a great Twitter. I really encourage people to follow him if you haven't seen him. And I don't know how much weight he's lost, but it's probably over 100 pounds, maybe even more now.
Wow.
And when I had him on, that was his breaking point was, you mentioned getting on an airplane. And so he got on an airplane and he wasn't able to fit in the seat. And so that was his breaking point. And he said, okay, I got to do something about this. And so, again, we don't want to shame people or guilt people, like you said, and we can certainly get into the stigma of obesity and a little bit later as well. But it seems like for some people having that sort of, initial or one point of like shame or guilt is sort of the shift forward. And so how do you kind of balance, I guess, not feeling shame and guilt, but also to, when you do feel that, to utilize it as motivation to go forward? And is that a conversation sometimes that you have with your patients, that like, hey, if you do feel this shame and this guilt, like maybe that's a sign that you do need to induce behavior change?
I look at shame and guilt as it's a suffering, and it's, I hear what it would be interesting to hear more about. It was a Dana.
Dave Dana is his
Dave
his
Dana.
name. Yeah.
It would be interesting to hear a little bit more about what that experience was like, getting on the plane and then feeling blame or shame as a turning point, kind of like a rock bottom. And yeah, I think rock bottom is or some kind of scare or something along those lines can be like anything, a change point. I don't feel that in general that's the motive that where I'm getting connected with people. It's more of a long-term suffering. Blame and shame has been with them since they were obese for many, many years. And most of the time it's thousands and thousands of, death by a million cuts. So that blame and shame, it can be a big thing. Some people don't have it, which is lovely to hear when they come in. They haven't experienced much bias or stigma or negative self-talk or attitude about body weight. But it's usually quite a large thing that they've been living with and hasn't been a motivating factor to kind of move towards positive change. Most of the time, blame and shame lead to counterproductive behaviors, disordered eating, avoidance, and a lot of these things. So it's kind of changing these moments from blame and shame to inspiration. Like what's the positive value? Instead of like, I really want to, it's pretty, putting a seatbelt on in the airplane, that's kind of like, but getting on the airplane to go where, to do something with who, you can get pumped up about that. And that can change towards fueling difficult things. So I'd look at it in that way. Blame and shame in general is a clinical approach is counterproductive. It's more of if a clinician is feeling frustrated with their patient for behavior change and we emote and try to induce blame and shame to create that rock bottom, the clinician might think they're doing good, but the evidence would say not.
Okay. So
it's much more likely for that patient to now do even more unhealthy things to avoid healthcare. The harm physicians have done through this is quite big, and it leads to healthcare avoidance. It leads to patients sometimes just feeling like they want to give up. So I'll quite often talk with patients like, hey, how's your experience been in healthcare around your body weight? And that's some of the trauma right there. The words we say in the clinic are extremely powerful. So if a patient's worked really hard at behavior change, they've lost 20 pounds and they go see the surgeon and they don't look at them in their eye and they just say, you're morbidly obese. I can't do surgery. You have to, eat less, without finding out who they are, what efforts they put in, and these kinds of things that the patient, that sometimes is like the tipping point, and very hard to get them back. So there's a lot of kind of decompression of that emotional experience for patients just interacting with us.
So what challenges in the healthcare system do we have now that makes it more difficult for people to lose weight?
I think, this kind of comes back to some of the things we've seen with like Make America Healthy Again. And what I see is a confusion about prevention versus treatment. So one big obstacle is our misunderstanding of obesity. So if you kind of think back to education, we got very little education on nutrition. That's true. We had even less education about obesity. And despite it being the most prevalent chronic disease, probably the most important chronic disease, in which leads to all these different chronic diseases that we see, that we label as different: heart disease, type 2 diabetes, fatty liver, et cetera. We got no training on what obesity is, like what's driving it. So we have a lot of assumptions of what it is based on just growing up as kids and society and watching the same movies and hearing the same conversations. So having a medical degree doesn't magically give us insight to obesity, nor kind of understanding it as a real chronic disease. So if we only look at obesity as a lifestyle issue, something that's a personal choice, a personal responsibility, and you kind of substitute that for heart disease or asthma, this is only a person's personal responsibility to treat their asthma or heart disease. Like, there's no need to think about medications here. Just exercise, eat less, move more, come back to see me later. Like that's probably the biggest obstacle. And then you have the policies and the structures and the manifestations of that ignorance, bias, and stigma in our healthcare system. So you have disproportionate funding and programs and so forth that for certain diseases, but not for others. So we haven't grown up yet, despite the science for the last 5 decades about what obesity is, and incorporated that really into primary care, surgical specialties. And it's still a very ignored disease, despite it being so prevalent. So it's kind of like the first thing we see and the last thing we treat.
So say you do have a patient who is motivated to change and they say, okay, I want to change my diet. I want to change my exercise routine. What specific diet do you recommend? Like, are you like a low carb guy? Are you more of like a counting calories guy? Or like, what specific diet would you, and I know it's probably, different for different individuals, but just on sort of like a gross population, level, like what kind of diet do you most likely recommend for patients who want to lose weight?
It's also quite personal. So I ask, find out exactly what their experience has been, what they've tried. A lot of times we think that they must not know nutrition, but if you talk with people with obesity, a lot of them can school us in nutrition and all the different dietary patterns and keto and low carb and different Mediterranean. They've done all the Weight Watchers and so forth. They can really school us on diet. Some are diet experts. They've gone through it all. And just literature wise, every healthy pattern of eating has about the same effect in terms of body weight. And maybe certain disease states like type 2 diabetes, if a person wants a lower carb approach, can de-escalate medications, perhaps a bit better than a low fat, healthy diet. And so it really depends on the person, what they want to try, what their home environment's like. And ideally you have a dietitian that can really go into that with them and follow along. So I've done like ketogenic dietary approaches for type 2 diabetes and had programs, and that's a lot of fun for patients that want to do that. But really that is coming back to who that person is and what they're going to find sustainable over time. And sometimes it's trial and error. All of them are going to cut through the trying to reduce ultra processed food consumption. So they have that common denominator, and finding foods that fill them up better, give them a good amount of protein, fiber, but then it's just kind of the overall dietary pattern. So I think having a dietitian or dietitians that are evidence-based, but really know that patient's values and know behavior change is pretty key. If we don't know the behavior change mechanics, all this knowledge of protein, carbs, fat, that's fine. But a sheet of paper doesn't do much. So it's kind of like, okay, what's happening at nighttime when Netflix comes on, and why are the chips coming out, and what's happening at that point? And like, I know I shouldn't be eating chips. Like, that's not on the food plan, but I'm struggling with it. So how do you work with that?
So one thing that I think helps a lot of people, and like, I do this myself, like there's no bad food in my house because like, I think I have pretty good willpower, but it's not perfect, So like if there's bad food in my house, like I might eat it, So
Yeah.
that's what kind of like saves me sometimes. So,
Oh man, I'm the worst.
so,
My wife's always like, what are you doing? Like if there's chips or it's like hand to mouth, and it's just going like if there's food around me, I want to eat it.
So is that something you tell your patients? Like, listen, we're gonna, start you on this diet. We're gonna, have you see a evidence-based dietitian who's, had success with some of my patients before. But the first thing I want you to do is just get rid of all the garbage in your house because that's step one. Do you feel like that's a relatively effective strategy for some people? And is that something that you tell your patients?
Yeah. So once you're kind of through the understanding their motives and goals and readiness, and they're in a green light, like ready to go. And then you've kind of understood the behaviors that they're having trouble with. There's definitely different approaches there, and food environment is one. So our deep brain's associative. So if Netflix comes on and we've been eating chips with it, next time it's nighttime, Netflix comes on, that deep part of the brain is going to fill in the gap with wanting for chips. And so that's that behavior. There's this like thing that's happening there. And once the horse is out of the barn, it's hard to refrain from. So you can kind of think about like what happens before the behavior, what the behavior is, and what the consequences are. So if the behavior is eating chips in front of Netflix, you're like, hey, that's a problem, that you see it as a problem. You want to stop. What are the things you'd like to do? And putting it in their court. But you can bring up for sure, like environmental change to allow success to be more likely. So not bringing the chips in is one thing. It might be though, depending on the wanting, they didn't bring the chips in and they're back in the car and going to the 7-Eleven or whatever to get the chips. But if you've approached it, there's readiness, making that environment as conducive to healthy behavior as possible. It's really important. But sometimes the chips makes its way back into it's kind of like this ultra processed food environment. It's like 70% of our food is ultra processed. A lot of families and people don't have full control over their home, kids or friends, or people are just bringing stuff in and it makes its way in. And so a person that is 100% committed to making their micro food environment good, there can be a cognitive like rigidness and lack of flexibility and freedom and fear of these foods. And they come in anyway, through the cracks in the door or whatever. But yeah, I think you're right. Like if you can make the environment conducive to healthy behaviors and make those easier, it's an effective strategy.
Yeah. I don't know if you're familiar with James Clear. He wrote Atomic Habits. So yeah, he just kind of talks about that all the time. Like make the environment very, very difficult for you to, continue those behaviors. I think one of the things I remember was like watching TV, and he said, unplug your TV and, put it in a closet or something like that. And then like, it just makes it more difficult for you to, do it. And then also too, then you're thinking about it, as you're doing it. So, you may just kind of, unconsciously, turn on the TV as opposed to, then you have to consciously go to the closet or go to wherever it is and take your TV, plug it in again, set it up and all that. So I do think that that's, something that can potentially help people in breaking, any habit.
Kind of a knock-on effect. I think he talks about this too, where one little decision point leads you to other decision points. And then if you take it far the way back, the initiation of the whole sequence of events may have been on the weekend where a person was doing meal planning and preparation and going to the grocery, but that weekend went off kilter, didn't have time. The week starts, and then they didn't prepare breakfast and lunch to take to work. And then after work, McDonald's is there. And then it all can start to unravel because of this kind of all or none thinking. Like, I went to McDonald's, I screwed up again. It's just not going to work. So some of it's kind of understanding how behavior change is hard. It's not linear. Mistakes happen. It's okay. You come back to kind of your goals, and then working with somebody that's not going to judge them. Say, hey, that's okay. Or sometimes when a physician hears, like, you come up with a plan to take the TV away, and the patient had a good plan. They come back, say, how'd it go? And then the person talks about like 10 or 15 things that are different from the plan you talked about. And kind of hearing that as excuses, when actually what you're hearing is life distress is happening. And when distress is happening, our healthy behaviors go down. So addressing those all those distresses is important. And then saying, hey, okay, at this point, given all that's going on, is there anything at this moment that you feel like you can do or want to do? Or do we need to just take a little bit of a break from that, and we'll come back to it? And then, so it's just kind of how to get back in the saddle over and over again.
How about psyllium husk, the active ingredient in Metamucil? Do you ever feel like, or suggest to your patients that, have a little bit of fiber before you start your meal, and then that should help, reduce your overall satiety, and maybe, you'll eat fewer calories overall? Is that something you incorporate?
Yeah, I think, like, say, nighttime eating is so common. Like, people, and often hear a patient come back and say, the dietitian told me I'm not eating enough. I need to eat more. And to lose weight. And it's like, I don't know what exactly that means, but I do think what's being intended is eating more wholesome food through the day, so that nighttime eating of the ultra processed foods is less. And so one experiment is like, all right, how about let's increase the protein and fiber content of food, especially earlier on in the day. So at nighttime, when we're tired and have less cognitive restraint, at least we're dealing with less kind of physiologic hunger. And the protein and the fiber, two of the constituents, like if you're just thinking about macronutrients that lead to more satiety, where high carb, high fat foods hit that wanting center, kind of opens up the third stomach or whatever. Like, I don't know if you've had that where my kids do, like, they're full, but then they find out that there's dessert or ice cream, and then there's like really hungry again. So there's other parts of the brain that are wanting.
Yeah, I heard, I think it was Max Lugavere tweeted out something maybe a year or two ago. There was a study, I think, that showed that if you start off your day with high protein, you end up eating less calories throughout the day or something like that. I can't remember exactly, but that's kind of interesting. And then also, too, I'm just remembering now, there's been, I think, quite a few studies that show that if you sleep less, you're more likely to crave like sugary foods and potentially eat more calories. So, fixing, some of those things can potentially lead to, better overall behavior change or better dietary habits.
I think you'll pick up a pattern of nighttime eating of higher carb, higher fat foods will impact sleep. Morning, people are less hungry, and then it kind of begets this issue. In the morning, they're like, I can't believe I did that again last night, so I'm just going to cut my calories today. And then the evening comes and hunger's back, and the wanting, and the cycle keeps going. We're retraining the brain to get to sleep a little bit earlier. Eating your real food earlier in the day can really help reduce that negative pattern. Sleep can get improved, and add in some physical activity. So sleep's a big deal. Sleepy brain is going to have a hard time. Cognitive restraint's lower. We kind of do a lot less fidgety movement, a lot less spontaneous activity. Post call, like I want McDonald's sometimes still, could be 8 a.m. I'd love to have a quarter pounder and a shake and fries. Like that's such a weird wanting, but if I'm really tired, that's what my brain's kind of looking for.
And so in terms of supplementation. Are there any specific supplements that you recommend to some of your patients for weight loss? Like, are there any supplements on the market that actually work?
No.
Okay. I like that answer. Short and sweet. So nothing really out there is really helpful for weight loss in any of these health food stores, and you don't recommend any of them for your patients.
No.
Okay. Excellent. So just before we get into the GLP-1s and Ozempic, we should talk maybe just a little bit about exercise. So, say again, you have, your dream patient to some degree, and, now they're motivated to exercise. What do you recommend overall for fat loss? You recommend just walking? Do you recommend, hit cardio? I mean, probably not if they're just getting into it. Do you recommend a little bit of strength training? Like, how do you approach an overall exercise program with someone who wants to lose weight?
One is like my personal patient population. I'm not in the field of people that are really healthy coming to me for health optimization. So I'm working with people with severe chronic disease quite often. Not all the time, but quite often. So I'm rarely seeing the person that is just killing it and wants to optimize their health further. So that would be a different kind of different kettle of fish, so to speak. So a lot of times it's understanding how important any kind of physical activity is and lowering the bar. So just knowing that getting up, anytime we start moving, it's a huge benefit. Standing, walking, anything is a huge benefit. And so sometimes people kind of think, what's the point if I'm not going to be doing a lot and, hammering it out at the gym? So any kind of physical activity is great. So it's, in terms of behavior change, it's kind of coming back to what they see themselves doing, what they enjoy. If they kind of see themselves walking, it might, kind of referencing James Clear again here as at first lowering the bar. So that first week you start getting into the habit, if daily walking is it, to lace up the shoes in the morning and open the door and up and down the driveway, and then optimize that and treat that habit for a week. And then now what's the next task? And is it walking around the block or whatnot? But really, I think resistance training, again, some people who haven't been in the gym or whatnot, that sounds intimidating, but elastic bands, having a kinesiologist would be, just phenomenal to work on resistance training. And I think that approach is going to become more and more important in time, where with medical therapy, if a person can experience it, they know what to eat, but it's that cognitive that wanting that's so difficult. So medical therapy kind of lowers the barriers to change, and they start eating well. That's great, but we also want to optimize and protect muscle mass. So resistance training becomes really key for function. So as people are getting older, they're getting a bit more sarcopenic, and we just know how important muscle mass and strength is for exercise will lead to some weight loss if somebody's really committed to it, but it's not as much as most people think. So I quite often ask them to really separate their body weight from the benefits of exercise and just look at the goal of exercise is to move and feel more fit. And it's going to lead to improved mental health and strength and longer life and less disease. It's just not going to impact body fat as much as one thinks.
Yeah, that's an important point. And I've heard Lane, talk about that before as well. I know I've brought him up a few times, but he said regardless of, weight loss, exercise is still incredibly beneficial to your health. So don't just equate exercise with weight loss. Exercise in itself is incredibly beneficial. And like you said, your mental health, gets better, your circulation gets better, maybe your blood pressure still drops a little bit, even though you're, not losing as much weight as, would want to with exercise, or maybe as much as you expect it to. One thing that I wanted to really ask you about too was, technology is becoming, more and more utilized these days in terms of, fat loss and that kind of things. People have Aura rings, people have so many trackers, Lang's got his own carbon app or something like that. Is there any apps that you recommend to your patients or any apps that you work with that you feel have been beneficial for your patients?
Um, I've worked a lot with a group called Constant Health, which is in Ontario. So Dr. Friedoff and his brother-in-law set up this where they have a professional dietitians and an excellent app for calorie tracking. But I think the brilliance of it is it includes behavior change, and then you also have a human on the other end. So I think that. Still at this point, despite all the technological advances, I think humans at this moment still need other humans and a community to move towards change and kind of look into the hiccups that are coming along the way. But tracking in itself is still really important and making it as easy as possible. So I'm still exploring apps and so forth. There's Chronometer and My Fitness Pal, those are all fine. RX Food is something that a Canadian physician helped start that uses AI for taking pictures, and it'll give you, just based on the picture, carbs, protein, fat, calories. So it's pretty cool. So AI is getting neat in terms of making tracking easier. Food diaries and things like that, like short term maybe. Really hard to do long term. So kind of, I think some really help to it's really like me personally, if I'm going to track my calories, it's really easy to do when I'm feeling really good about what I'm eating. But then if there's something I'm not so proud about eating, I'll either omit it in my head or not write it down. So I think that is hey, let's take 3 days, the patient, we're going to review it, and they have to feel comfortable that there's not going to be a judgmental atmosphere. But it's awakening for a lot to say, I hadn't really thought about these other times in between meals of what I've been eating. And it's interesting to see how many calories are there.
And so regarding steps, you hear about 10,000 steps, like every day someone's kind of, tweeting about it or writing an article about it, something like that. I imagine though, for, a lot of your patients, maybe not for all of them, maybe they're only at 2,000 to 3,000 steps or something like that. And so maybe you just recommend hey, try to get an extra 100 steps this week or an extra 200 steps. Is there any specific sort of goal or a specific regimen that you've found to be helpful in terms of most of my patients get better when we only say put the pressure on them to add an extra 500 steps over 1 week or 500 steps over 2 weeks? Anything specific like that you found, or maybe there's some research on it that you want to share?
I'm neighbors with Jonathan Fowles, who was involved with exercise medicine, and so he's at our little Katie University. So I don't know if you use this, but an exercise prescription can be really helpful. And so we know an exercise prescription increases the likelihood of physical activity over time.
So I'm not really familiar with exercise prescription. If you can just maybe.
So it's and on the website, exercise is best medicine or exercise is medicine. It's just a script.
Okay.
And so it's negotiated with the patient, finding out what they're wanting to do, what they're wanting to achieve, kind of keeping, understanding the tenets of achievable goals, and where they are now, where they want to go. And, just writing it out. Like you said, if it's 2,000 steps today and they are okay, this week I'd like to go to 2,500, sounds perfect.
Okay.
So I think that kind of graded exercise program, taking people where they're at, maybe for some it's squats from seated position, if they can do squats, and maybe it's kind of exercise snacks, doing these kind of 3 times a day, just interrupting sedentary behavior is really cool. And then other people are doing 10,000 steps a day. That's exciting. They're starting to they find somebody, online that they're doing, doing more more and more fitness or getting into high intensity exercise, then it's like, this is something to celebrate.
Excellent. So I know I only have you for, a few more minutes. Hopefully we can go over just a little bit more if that's okay. So,
Yeah.
we kind of covered diet, we covered exercise, we covered behavior change, we covered supplements very, very quickly, but we did cover them. So let's talk about, Ozempic and the GLP-1 agonist. So, is this something that you prescribe to your patients, and have you had a lot of success with it overall?
Yeah, it's kind of, when you think about obesity medicine, which is really just medicine, you think about three pillars: behavior change, medical therapy, and bariatric surgery. And the point of all those is you can kind of look at the brain and understand why we're thinking about these treatments for obesity, and understand where obesity resides. And on one way, a person might be like, okay, obesity is just excess fat. That's where obesity is. That would seem to make sense. Other times it's like, well, actually it's the fat that's not in excess, but it's dysfunctional. And that's leading to things like type 2 diabetes. And so behavior change is one component. Exercising, movement, refraining from going to McDonald's, things like that. But over time, obesity is really about a dysregulation of the energy regulatory center in the deep brain. And that's a non-conscious part of the brain. And so just as you kind of talked about exercise and change, kind of separating that from body weight, also important to do that with nutrition. That nutrition will directionally move people towards a healthier weight. But if we're stuck on the scale, most want to lose like 30% of their weight. What they're typically going to experience is the deep brain's defense against weight loss over time. So brains are okay losing weight over a 6 to 9 month period, and then something seems to halt it. Weight doesn't just keep going down to normal, despite a lot of what's talked about in the wellness industry and all the different, you can say that's diet culture, that weight is a choice. If you just work hard enough, you're going to get to whatever weight you want to be. Actually, there's a really powerful defense that's kind of evolutionarily present to defend against weight loss. And it allows a certain amount of weight loss, but then there's a plateau that happens. And some might say, I'm going to white knuckle willpower through that and just refrain from eating. Eventually the brain bounces back, and there's that yo-yo diet experience. So some of this is kind of like, hey, let's work on nutrition, exercise. Most likely something's going to happen and weight's going to kind of start settling out. You can kind of play with things. A person could say, I know I could do this to get to a lower weight, but my life isn't going to be enjoyable. It's not going to be worth it. And it's finding like, okay, acceptance or contentment at that weight, which is sometimes like at year 3 to 5, like a 5% weight loss, which is important health-wise, but often there's this huge therapeutic gap where lower weight would help resolve more obesity-associated symptoms. So then you have the role of GLP-1 therapies, GLP, GIP, to treat the part of the brain where weight is being regulated. And so that's where you're like, okay, obesity actually resides in the deep brain, in these non-conscious circuits where energy homeostasis exists. And so by doing that, you're kind of bringing the thermostat for weight down, or like a dimmer switch. Still, you're going to meet that brain's defense against weight loss, but it'll be at a lower weight. And on average, like with Wegovy, which is the semaglutide at the higher dose at 2.4, kind of like 12% extra weight loss, where Ozempic at 1 milligram is around 7% extra weight loss. That's equivalent to Saxenda. And so these were kind of modestly effective. And the newer pharmacotherapies in the pipeline are going to be getting down to more like 20% weight loss. And bariatric surgery is more of a 25% weight loss. And that's really the potency of how bariatric surgery affects gut hormones that speak to the deep brain. So once you're at that point, you're like, oh, okay, obesity is a chronic disease. There's things we can do to behavior change, just like any other chronic disease. There's also medical treatment and surgery, just like any other chronic disease. And so it's physicians that's kind of breaking free of this idea that, hey, body weight is just under conscious control. You just work hard at it and you'll get to whatever weight you want. Is similar to telling somebody with bad asthma, just keep dusting. Just keep dusting, get rid of the cats, move to Arizona. You don't need bronchodilators. You don't need biologic agents. Just keep working at it. So it's very similar. There's a biologic fundamental level of obesity that we need to appreciate.
And in addition to Ozempic, the one that a lot of people are using now is Munjaro. And so my understanding is that, Ozempic is, only has one mechanism of action. It's a GLP-1 agonist, whereas Munjaro is a GLP-1 agonist. And then it's also, correct me if I'm wrong here, it's a GIP agonist as well. And so people and some of the studies have shown that they are experiencing more weight loss with Munjaro than Ozempic. So, would you just do away with Ozempic altogether and just go straight to Munjaro, or what are your thoughts on that, and what's your approach for your patients?
So in the States, it's FDA approved under the trade name Zepbound. So Munjaro, once you treat obesity, is called Zepbound, like same drug, they just named it different for whatever reason. So in Canada, it's still been a slow rollout for Munjaro. It has Health Canada approval for type 2 diabetes. And the request to Health Canada is in for the obesity indication and will likely also be called Zepbound. And head-to-head trial, Wegovy versus Munjaro or Zepbound. Munjaro beats Wegovy. So you get 3 to 5% more weight loss with it. And seems like a little less side effect as well. So GIP is another hormone that the gut makes. So you have GLP-1 and GIP, and these are kind of hormones that our body makes, and pharma has kind of modified them. GIP looks a lot like GLP, it's just a little bit different. And if you gave somebody GIP by itself, it doesn't do much. So it kind of went on the back burner for a while, but when you combine it with GLP, it's a synergistic effect. So maybe a little less side effects. So I think that's what we'll see is you have GLP, GIP, and you have glucagon, amylin. So they're coming up with all these different hormones, and you combine them, you get more synergistic effect and likely less side effects. So more benefit, less side effect. And then eventually we'll have, these are all peptides, as you know, a bit hard to make peptides. And so eventually we'll have just chemicals that hit the receptors that don't need to be peptides. So that will probably be part of the future as well. Easier to make.
And in terms of, some of your patients, like, you talked about, obviously this is, approved for type 2 diabetics. Do you have some patients who, maybe they lose weight initially and then, their weight slows down, but even with the weight slowing down, they still improve like their metabolic health overall? So say like their hemoglobin A1C, which is, I think an excellent test. And for people who don't know what that is, it's a measurement of your blood sugar over 3 months. So, maybe they don't hit their weight loss goal, but they're able to bring their A1C down from, 7 or 7.5, whatever it is, to, a normal range of 5.4 or 5.5, something like that. Like, do you have a lot of patients like that?
Yeah, I think you'll find with Munjaro and Ozempic, for instance, in diabetes, it's like a 5 to 7% average weight loss. So it's not that dramatic. Some will lose 20% and some will lose less. So a lot of variability in response. But a 5 to 7% weight loss with diet alone will lead to improvements in glucose. And essentially, the first fat loss is going to typically come from the viscera and the ectopic fat in the liver and the pancreas.
Which is the most important fat to lose, correct?
Yeah. So you're going to improve all the hormone signaling and insulin resistance in the liver, and glucose gets a lot better. We do know, like, if you find somebody really early in their diabetes and they lose 15% of their weight or 15 kilograms, extremely higher likelihood of remission for type 2. But even with like Ozempic, one of the things it does is if one eats carbohydrates and glucose in the blood's high, it'll help the pancreas make insulin and help dispose of that glucose better. So that's another kind of effect of these therapies is they modulate insulin production on exposure to carbohydrate intake.
Okay, so for my perspective and from a lot of people's perspectives, it's simply just that these medications make you eat less, and like that's basically the main mechanism probably for weight loss. But overall, they are having other mechanisms of action, other beneficial effects overall. Is that correct?
Yeah. So weight loss will come through. I think they're misunderstood as appetite suppressants.
Yes, because that's what they're generally, sort
called.
of marketed as, or sort of not necessarily even marketed as, just understood as overall.
And a person will experience decreased appetite. But really what they're doing is kind of treating that dimmer switch in the deep brain where weight is regulated. So you kind of have hunger circuits in the brain and full circuits in the brain that are working over large quantities of time. And by kind of modulating that through the hormones, you bring that thermostat down. And when the thermostat is lower than a person's weight, they'll experience low appetite. Then as the body weight comes down to that new steady state, the wanting and the hunger come back just at a lower body weight. And a lot of times people experience that as the drug not working anymore and stop it. And you ask, why'd you stop? Well, I stopped losing weight. I kind of got stuck here. And you look back and it was like a 10, 15% weight loss. And now they're back up to their weight. Now they're regaining weight. And you're like, well, maybe it was working. It works. Weight loss, like the same effort, the same treatments that lead to weight loss need to be continued at weight maintenance. And that's one of the key things. The diet, same kind of effort with diet, the same exercise, the same drug therapy is key. So that's really important to kind of emphasize. Most people, when therapy stops, start moving back towards their previous weight. Occasionally, somebody can maintain a lower weight, and probably need more studies to look at who those people are. But 80% or so regain most of that weight. So that's kind of it's an obesity drug rather than an appetite suppressant. And then there's weight dependent. A lot of benefit comes from weight loss. Decrease inflammation, improved insulin sensitivity, reduce visceral fat. But these molecules are also affecting things in the vasculature. They're directly affecting things in the inflammatory kind of cascade, improving insulin sensitivity in organs themselves. So some of it's from weight loss, but then there's also weight independent effects of the therapies that are leading to some of the cardiovascular preventative aspects.
Okay, so I know we've gone over, but I just have to ask you one more question, if that's okay. So have you had someone who's, come in, struggled with obesity, but they're also struggling with alcoholism or some other type of addiction, and then they take Ozempic or they take Munjaro, one of these medications, and then they say, you know what, like, yeah, I'm losing weight, but I also, don't want to drink as much, or I also, don't want to use cocaine as much, or whatever the addiction is that they have. Have you had any patients like that?
I haven't. I'm always skeptical of my own anecdotal experience, but you will hear these things from patients. Spencer Nadowski and some colleagues looked retrospectively at data, I think from the Weight Watchers and sequence data where there's a medical side of it. I could be mistaking some of this, but they looked at it retrospectively and saw reduced alcohol intake. And I do know one of the pharmaceutical companies is going to look at it in terms of an RCT. So alcohol intake and wanting, those same neurobiologic circuits are involved in those kind of the wanting and motivation side. So it would make sense that there's a mechanistic likelihood that modulating these deeper centers and that limbic system is going to reduce wanting of other things. including alcohol. So looking forward to hearing what those studies show. So I think if you're, one, reducing alcohol is really helpful for weight loss to begin with, just because the body's going to preferentially burn alcohol because there's no place to store it. And in that way, it's excess calories. But and that can be a hiccup for people in terms of wanting to improve their body weight, is loving wine or beer or whatnot. And so you start therapy. They start noticing other benefits in life. Sometimes people even are like, didn't talk to them about exercise. And they come back and they're like walking. Like, how'd that happen? Well, it just spontaneously started feeling better and started moving.
Awesome. Well, I'm definitely looking forward to that research. So thank you so much for coming on the show today, but please let people know, your Twitter handle, where they can find your clinic, and anything else you wanted to share about yourself.
Sure. The Twitter handle is Michael Mindrum. And then you can find me in Nova Scotia. So I have a website called Valley Metabolic Health. And one thing I do share with patients is a course that's free called Empowered Health. And that just takes people through kind of a curriculum with some videos about what obesity is, how body weight is regulated by the brain, role of behavior change, medication, surgery, and kind of thinking about this as a chronic disease, with the idea that if patients really understand their disease better, they can advocate for change, ask doctors for support.
Awesome. Well, thank you so much for coming on today. I learned a ton. I'm sure everyone who listens to this, has learned a ton as well. So, you obviously know an incredible amount about obesity, and I'd love to have you back on the show sometime.
Awesome,
especially as more research comes out, when you learn more and more, because I think this is a very, very rapidly evolving field. So I'm sure that in 6 months or 12 months we'll be able to talk about something almost entirely different. So thanks so much again for coming on the show, and thank you so much everyone for listening. And as always, I'll be back again with another episode soon.